turbo engine running.
Absolute genius.
Get this.
Welcome.
This is the show where we bring you
Science.
What that essentially means is
discoveries,
Advances.
questions,
Research.
technology.
Unbelievable.
Without further ado,
This is The Naked Scientists.
Hello and welcome to The Naked Scientists, the show where we bring you the latest breakthroughs in science, technology and medicine with me, James Titko. Today we're examining obsessive compulsive disorder, what it's actually like to live with the condition and the new ideas shaping scientific research into treating it.
From Cambridge University's Institute of Continuing Education, this is The Naked Scientists.
Obsessive compulsive disorder, OCD, is a mental health condition where intrusive, unwanted thoughts can become all-consuming. Some people report anxieties over something terrible happening to them or someone they love, for example. And in some cases, in a bid to alleviate these fears, they may carry out compulsive actions repetitively to the point that they become extremely disruptive to their lives. Due to pervasive misconceptions around this serious psychiatric condition, a lot of people suffer with their symptoms for a long time before getting help. It's also complicated to unpick the mechanisms of this disorder, and we'll be exploring the ideas at the cutting edge of current research later in this programme. But first, to help us understand a bit more about OCD, I've been speaking with Patrick Dolan, a third-year student at the University of Cambridge. He first started noticing abnormal behaviours when he was 16 years old.
Checking doors were locked, checking I hadn't left the hob on, continuously making sure my dog was inside and I hadn't left him outside when I was about to leave the house. It also manifested in ways in my studies. So I had to constantly reread paragraphs because I wasn't sure whether I'd completely understood it. I'd get stuck on certain pieces of work because completing it just didn't feel right. And turning in assessments and just they had to be perfect for the teachers.
Distortions of useful behaviours, checking your work, something that would make sense to do, making sure the hob's not on so you don't burn the house down. But how would you describe it to someone who's not familiar, where it turns into something more than just a rational thing?
Like you say, a lot of the behaviours actually stem from normal things you would do every day. However, the obsession comes when, so you go back to it multiple times. So even if you see, for example, that the hob is turned off, it doesn't feel right in your head that it is turned off. And that's where the compulsions kick in. So you might need to turn it off and on, off and on, off and on. You might need to keep revisiting it. Or in some more severe cases, if it's not treated, you might, for example, leave the house and get 5 minutes down the road and then think, oh no, did I turn the hob off? And in some cases, that might require you to return back, go into the house and check the hob is off. And that cycle can go on forever and ever until you actually feel satisfied in yourself.
It's, I can imagine, extremely exhausting when people claim to be a little bit OCD, which is kind of a gross misunderstanding of the genuine psychiatric condition experienced by people like you.
Exactly. And I think, for example, if you say that you have depression when you haven't actually been diagnosed with it, people will call you out and say, oh, you can't just say you're depressed because you feel a bit sad. That's not fair on the people that are actually suffering from depression. But if you get people saying, oh, I'm so OCD, I like to color coordinate my notes, I have to have everything lined up, they might actually be OCD symptoms. But if you haven't been diagnosed and it's kind of clear you don't have the condition, then it can be upsetting for people that do. And I'm not saying people do this maliciously, but I think now as we have these conversations, it needs to be something that we stop saying.
I think you're definitely right there. As you got older, did your OCD change in any way?
The best way to describe it to you is that it shifted from the compulsions more into my head. So it almost became more of a mental health issue because there weren't physical symptoms of it anymore. I wasn't tapping or checking. I admit, I think this probably came from a bit of shame. I didn't really want to speak about it when I was younger. And I noticed that people noticed I was behaving in certain ways. So I think I tried to stop and repress the compulsions as much as possible. But as you'll know, that's just not possible. it kind of went more into my head and it became more of like a purer form where it just completely affected my thoughts and I had less compulsions, but it was stronger than ever, really.
And it's just this sort of overwhelming feeling of, I guess, powerlessness against the thoughts inside your head.
Exactly, yeah. It's like my brain blackmailing itself. Like it wasn't sure of where it stood in any situation.
How have you managed to manage the condition, I guess, whether it be in those earlier years or more recently, to limit the flare ups?
So to be honest, the best thing I did was to start speaking about it. I didn't know anybody else that had suffered from such a thing. I kind of felt so different to everyone else. I'd heard of depression and anxiety, but I hadn't seen these symptoms in real life. It's only coming to Cambridge actually, when I first got there in first year, that I found a lot of people were very, very comfortable about speaking about the condition. And that almost gave me the confidence to be like, okay, I'm not alone. And it's from there that for the first time I could say stuff out loud. I could admit it to other people, to my friends without and my family without feeling I was different or I was strange. And it was only these conversations that actually maybe go and get help, go to the NHS and get cognitive behavioral therapy.
Patrick Dolan describing his experience of OCD. We'll hear more about the treatments available that Patrick mentioned at the end of that interview a little bit later. Before that, though, we need to try to understand what's going on inside the brain to bring on these obsessions and, in some cases, compulsive behaviours. Trevor Robbins is the man to help us here, a professor of cognitive neuroscience at the University of Cambridge.
The classical idea would be intrusive thoughts are often very unpleasant and cause anxiety, and in order to cope with this anxiety and reduce the stress, you perform this repetitive behaviour, so it's a kind of coping response. And there may be some truth to that, but the evidence, isn't totally clear. And it's interesting from a psychological point of view that we know that avoidance behaviour, for example, in the lab, often develops into what we call habits. And habits are more automatic, and they no longer really depend on the original conditions which produce them. In other words, you might perform the behaviour initially to reduce anxiety, but then you just do it automatically. And the anxiety kind of is irrelevant then. In the brain, there's a balance between your goal-directed behaviour and habits. And we think it's kind of flipped over a bit to the habit system in OCD. And so that's partly why it becomes more automatic and less amenable to cognitive manipulation, as it were.
Fascinating to hear the kind of nuance and the active debate clearly on this particular condition. If we were to stick with the classical model for 1 minute, what's the psychological sequence of thoughts that leads some people to demonstrate the behaviours, the compulsions that we see? Because I think there's quite a few misconceptions on that topic.
There's a lot, and OCD is expressed in a variety of ways. But the classical example really is germs, fear of infection. And so this leads to excessive hygienic behaviours, washing your hands so often with bleach that you actually cause damage. Then clearly it's a compulsive behaviour. Another classic example really is checking whether you've locked the door after you've left your house, and maybe spending 15 or 20 minutes to ameliorate this anxiety that your house is going to be violated in some way. Checking, by the way, is a very fundamental symptom in OCD. I mean, even if you're afraid of germs, essentially you're checking all the time whether your skin is clean. OCD can often extend into other areas, for example, perfectionism and ordering, which is a more cognitive aspect. But again, checking is important there, checking that the arrangement is perfect, checking uncertainty. Uncertainty is core to OCD. And the issue, I suppose, is whether uncertainty causes inappropriate anxiety, which is relieved in some way.
And these compulsions, they have, on the face of it, a practical and reasonable reason for doing something. So checking, for example, that you haven't left the oven on, that makes sense as something to do.
Yeah, absolutely. So in a sense, habits are obviously very adaptive, and leading them into compulsive behaviour is also adaptive in some sense. I mean, as a scientist, I'm fairly careful and compulsive and checking. If you're proofreading, for example, that's a skill that you have to develop, being very careful and checking everything is correct. So, in a sense, we all have a bit of OCD. And what I would argue is that there is a dimension of behaviour called compulsivity, and extends in very normal areas, for example, stamp collecting or something like that, but then gradually becomes excessive. And there is a point where this tendency to compulsivity is maladaptive because it stops you doing other things, for example, or you're not even doing the thing you wanted to do in the most efficient manner. And it's really interfering with your life because you're spending all your time doing this behaviour.
It's interesting because one of the key frustrations I find, having spoken to people with quite debilitating OCD, is this people describing themselves as a bit OCD because they like to keep their room tidy or because they engage in other sorts of behaviour. So I was interested to pick up on that.
It's a major problem, I think, really socially, because OCD is stigmatised, and that, I think, has prevented large attention being devoted to it for treatments and so forth, and research activities. So this has to change because it's a very serious and disabling disorder in quite a large number of people. The incidence is 2 to 3% of the general population, which is enormous.
That's the kind of psychological grounding. This is manifesting in a wide variety of ways, as we've described and touched on, presumably with a common neurological basis.
Yes, indeed. So I said earlier, one way of thinking about this is a bias towards the habit system in the brain from the goal-directed system. And, there's a lot of brain scanning experiments in humans and experimental animals showing this dissociation between the systems. And you can discern some of this in OCD patients. But I think there's a third factor. And the third factor relates to the system which controls the balance between these systems in the frontal lobes of the brain, in the frontal cortex. We call this the arbitration system, and it's mediated by parts of the frontal cortex and the striatum which seem to switch in whichever behavioural system is required. And if this switch is a bit inefficient, then you're going to end up with habits. Compulsions aren't simply habits. They're habits which can't be regulated, which you can't inhibit. And OCD patients also are a bit rigid cognitively. They're cognitively inflexible, if you like. And so that doesn't help either.
A lot of people who experience OCD will point to trauma earlier on in their life. Can you elucidate the detail as to why that might be related and where that fits in the psychology or the neurology as you've described it?
Yeah, that's a very interesting one. Well, yeah, trauma obviously is associated with stress, and really it comes back to what I was saying earlier, that maybe you have to cope with that stress. You have to protect the brain. You feel anxiety as a consequence of the stress, and you indulge in these compulsive behaviours in order to reduce the stress. So that's the hypothesis. On the other hand, the other possibility is that something in brain development just goes slightly wrong and you find yourself repeating your behaviours. And one idea we've had is that when that happens to you, that makes you anxious as well, because you have to find reasons to explain why you're doing this weird behaviour.
Indeed. Many thanks to Trevor Robbins from the University of Cambridge. And you can hear more from Trevor, who's going to be a guest on our upcoming series of Titans of Science. So stay tuned for that. You're listening to The Naked Scientists with me, James Titko. Today we're looking at obsessive compulsive disorder. So far, we've heard about what it's like to live with it and where we are in understanding the neuropathology of the condition. That is, what's going on inside the brain to bring on the symptoms. And it's important to remember, OCD diagnosis can take a really long time. On average, it takes 8 years from when somebody starts noticing symptoms to be diagnosed. And that's because of a number of reasons, as we've covered so far: poor understanding of the condition amongst the population, a stigma towards the compulsions, but also, crucially, the lack of screening of the condition by medical professionals in primary care. Once patients do get over the critical hurdle of diagnosis, effective treatments are out there. But it is something of a mixed picture, hardly surprising given the evolving theories as to what the mechanism behind the condition actually is, as we were covering with Trevor Robbins. But here to talk us through what we do know is Camilla Nord, who leads the Mental Health Neuroscience Programme of Research at the MRC Cognition and Brain Sciences Unit at the University of Cambridge. We started with the gold standard first-line treatment for OCD, cognitive behavioural therapy.
In the context of OCD, cognitive behavioral therapy, or CBT, is a kind of talk therapy, but it's a little bit different than the way you might think about talk therapies. It's not dealing with sort of, your history and your family and where these things might come from. It's dealing with symptoms often in the here and now is how you can think about it. And one aspect of CBT is the cognitions that you experience. And so there you might work on why you have certain thoughts that emerge and perhaps re-examining, or it's called restructuring those thoughts. And then particularly crucial in OCD treatment is the B part, the behaviors. And even if you don't experience compulsions, as some people with OCD don't, actually the behavioral part of CBT is really crucial, because this often involves exposing you to the very things that you're having intrusive thoughts about, and then working on those reactions, often little by little. So starting with something very at the minor end of what you're having intrusive thoughts about, and working up to maybe a more realistic setting of what you experience day to day.
You kind of expose patients to a scenario that will set off their anxiety in a controlled environment, a bit like you're exposing their brain to a small dose of a disease via a vaccine, in the hope that it develops a strategy, the antibodies maybe, to be able to overcome the fear in the future.
Yes, exactly. So if you're particularly worried, for example, about germs on something that you're about to eat, you might work your way towards eating it, starting with maybe handling it and observing, experiencing that you don't become sick, you don't have consequences from that. And then I think I remember one context of a therapist not washing their hands after the loo and then touching a biscuit. We can all imagine how that might be a bit gross, but for someone with OCD, that is a prohibitive, intrusive thought that they might have, and that might lead to the kind of compulsions that they experience. And so working up to maybe even being able to eat that biscuit.
Wow. Yeah, no thanks. We hope that works for as many people as possible, but I think I'm right in saying CBT works for roughly 75% of patients, which leaves a significant portion for whom it doesn't work.
Yeah, and I should say that's 75% for whom it works a little bit. So they have a response to it, which would mean a kind of noticeable reduction in your symptoms. Even in that 75%, there will be a substantial number of people who have some residual symptoms. It doesn't necessarily make them totally go away.
Right. And to compound that, we have the issue that it can take an extremely long time to see a psychiatrist, in this country anyway.
And I think that presents a challenge, because for that 25% who don't experience really any noticeable change in their symptoms, there are other strategies that exist, but they might be difficult to access. So, for example, some people respond very well to the high dose of antidepressants, the most common class of antidepressants called selective serotonin reuptake inhibitors, or SSRIs. But with that, you would want to be working with a medical doctor to work out the right dose for you, ensuring that you don't have side effects and so on. And sometimes those can be used in combination with CBT, and it actually helps you access the CBT to have that pharmacological intervention kind of achieves the goals of the psychotherapy that it might not achieve on its own.
That is a really interesting point with regards to what I wanted to ask next, because as we've been hearing, there's active debate as to what the mechanism of the disease actually is. And you'd have thought that would be a very pertinent point to finalise with regards to what treatments are going to work. Is OCD caused by a chemical imbalance in the brain from overactive stress response, or, as others argue, perhaps it's a bias towards the habit network in the brain and against the goal-directed system, for example?
I'm not sure that I agree that the treatments would be different depending on whether you think of it as a chemical imbalance or not. So I don't think of OCD as a chemical imbalance. I think many neuroscientists don't. Brain networks, it might not even be exactly the same change in every patient. Nevertheless, we use lots of drugs for things that aren't just a deficit in that problem. You know, paracetamol works without you having to have a deficit in the specific thing that paracetamol is targeting. So I think SSRIs have properties that can change brain networks. And so it's sensible that they might be working in OCD without necessarily curing some sort of decrease in a brain chemical.
Well, tell me then about the interest in deep brain stimulation, because that's more going along with this kind of new school of thinking around OCD.
So, deep brain stimulation is a treatment that originally comes from Parkinson's disease. The way that it works is surgically, neurosurgeons implant electrodes deep in the brain in the structures that we know to be involved in OCD. And then by delivering electrical currents to those regions, it can change the biasing of brain networks in a direction closer to people without OCD. Whether or not it works in OCD was something that has now been explored in a couple big studies, and there does seem to be effectiveness. But I think the problem, or I suppose the challenge with deep brain stimulation, is you have to get the target right. And so there we get back to the idea of, does everyone necessarily have the same region that should be targeted? Overall, these are patients who don't respond to anything else. And this intervention works in, I think, more than half of them, I think over 60%. So that is still a really useful and effective treatment. But I would say that in the long run, for most patients with OCD, they might not be candidates for something as risky as neurosurgery, but there might be other ways of changing those brain networks, for example, with non-invasive brain stimulation.
Quite. And to go a step further then, what about psychedelics? Because there's obviously interest in using psilocybin, ketamine for treatment-resistant depression. The theory being that they also work by encouraging the growth of connection between systems in the brain, like you were just touching on. So could the success they show there be encouraging for people with OCD?
Yeah, you're right. I mean, the interesting thing about ketamine is in OCD, like in depression, SSRIs, the drugs, take a really long time to work. And yet, ketamine in depression is a rapid acting antidepressant. So it's very effective for many patients and it works quite quickly. That would be incredibly useful for people with OCD to have more immediate relief from these very debilitating symptoms. In many cases, the jury is still out. So I think there is probably a little bit more work that's been done now on ketamine than on, say, psilocybin, which I think is truly ongoing, because you really need things like a robust placebo group working at the level of, is it this specific or is it your expectations of getting better, which are incredibly powerful unconscious drivers of treatment response in many cases.
Some very exciting developments could be just around the corner then. That was Camilla Nord at the University of Cambridge, walking us through current treatments for OCD and promising emerging ones. But to conclude today's programme, we're going to move on from looking solely at the workings of the brain in relation to OCD and incorporate the growing body of research into the body's so-called second brain, the gut microbiome. It's no doubt a very trendy topic with so much ongoing research into how the diversity in the species of the 100 trillion or so bacteria in our guts can impact all facets of our health, something we've talked about before here on the show. But here to provide us the picture as relates to OCD is clinical psychologist Stephanie Fitzgerald.
really, the reason people started to talk about the second brain in the gut is because the same chemicals that are found in the brain are also produced in the gut. So, for example, serotonin. The availability of those chemicals to the brain can be governed by the activity of the gut bacteria.
And you mentioned serotonin there. One of the mainstream treatments for OCD is SSRIs, serotonin reuptake inhibitors. So obviously it's going to be crucial to how they work if a high proportion of the serotonin in our bodies resides in our gut.
Yes, absolutely. And a lot of medications which focus on serotonin, actually, there's a precursor to your serotonin, a necessary precursor, which is tryptophan. And your levels of tryptophan in your body are very tightly governed by your gut bacteria. So even if you're taking a medication to enhance or promote serotonin, if your gut bacteria isn't healthy, if your gut microbiome isn't healthy, then actually you may struggle to get the full benefit of that medication, even if you're taking something very specifically focusing on serotonin. It's very similar to if ever you've taken an iron supplement, but your vitamin C levels are low, actually you're going to struggle to get the benefit of that supplement. It works in the same way. If you're taking serotonin, but your tryptophan levels are out, you're not really going to see the full benefit of that medication.
So if we broaden out and think about mental health in its entirety, tell us about why the gut plays a role there.
If we think about it more broadly, our microbiome also affects our mood, our libido, our metabolism, our immunity, our perception of the world, and the clarity of our thoughts. So if we think about, for example, depression and anxiety, we know that whether we feel full of energy or demotivated or very lethargic, these things can really show up as symptoms of depression or anxiety. And so really, our microbiome could be said to control every aspect, or certainly contribute to every aspect of our mental health and how we feel physically as well as mentally.
And then if we come back to OCD, the compulsions people exhibit caused by stress, does the gut have a role with regard to how patients might fare? What about a mechanism there related to stress?
Yes, absolutely. And really, it all comes down to inflammation, what we call inflammation in the gut and gut permeability. So, high levels of inflammation in the gut dramatically increase that risk of developing depression and anxiety. And if we think about OCD and symptoms, the higher the inflammation in the gut, the higher the level of anxiety and symptoms you're likely to experience. And actually, there's quite a bit of new research which is suggesting that some antidepressants, for example, actually target inflammation in the gut now rather than directly impacting the brain. So the acknowledgement is sort of actually, if we soothe and calm this inflammation in the gut, we're going to reduce symptoms. Now, the thing with OCD is obviously it's an anxiety disorder. The anxiety response runs on the same mechanisms, if you like, as the stress response. And your gut microbiome and the levels of inflammation are going to affect your stress response. And they will also affect your reactions in stressful situations. So those compulsions won't necessarily go away, but the distress that they cause, the level of anxiety around having to do them in a certain way at a certain time, that can be managed by a much calmer gut.
And Stephanie, maybe we've fermented some inspiration in our listeners. What are the foods we should be looking at to help with our gut health?
So it's a great question. And what I will say is that it doesn't need to be expensive. I would always encourage people to start supporting their gut health with a simple probiotic supplement, but actually beyond probiotics, it's looking at things like live cultured yogurt, for example, things like kefir, which is a fermented dairy product, things like kombucha tea. Again, it's a fermented tea. It's slightly fizzy. You serve it chilled. Again, it's quite easy to make yourself. And then more broadly, you want to have a very varied diet that's good for your gut. And we do have this sort of good food for good mood guideline where you want lots of vegetables and a good variety of vegetables. Your plate should look quite appealing and quite colourful. That's a really good way to see, am I eating something that's good for my mood? So if you take something like chicken and chips, that's a very beige meal. There's not a huge amount there that's good for your mental health. But if you look at a chicken salad, suddenly you've got all those colours on the plate and you think, oh, okay, this is doing me some good.
That was Stephanie Fitzgerald. Thanks very much to her. And it goes to show that for what can be such a debilitating disorder, there are plenty of interventions that do show quite a lot of promise for helping with OCD. For many people, it's a case of having the bravery to seek help if they notice intrusive thoughts persisting in the way in which we've described on the programme. Next time, we're kicking off a new series of Titans of Science, the series where we deep dive into exciting research and fascinating historical breakthroughs with figures at the top of their respective fields. First up, it's astrophysicist Jocelyn Bell Burnell, who will be talking about her trailblazing discovery of radio pulsars. The Naked Scientists comes to you from the University of Cambridge's Institute of Continuing Education. It's supported by Rolls-Royce. I'm James Titko, and from everyone here at The Naked Scientists, thanks for listening, and until next time, goodbye.